same, EKG and ECG. In America, we call it ECG, electrocardiogram. The C for cardio, right? In Europe, they use the K for cardiogram. It's identical though. We're still talking about the same waveforms, right? And the same exact meaning for those waveforms. So in ECG, we see three main waveforms that are important. The first one is called the P wave. The P wave is called is a sign of your atrial depolarization. So the atria is depolarized. Now, what else is it a sign of that? Right? Why do the atrial muscles depolarize? They depolarize because the SA node has fired, and the SA node is stimulating the whole cardiac cycle. So seeing this P wave is a sign that the SA node activated, which is good. We want to see a P wave. We want the SA node to be normally firing and driving our cardiac conduction system. When it does do this, we have a normal P, and then QRS, and then a T. We see you have normal sinus rhythm. That means the normal SA node activity is driving that cardiac rhythm, which is something we want to always see. Normal sinus rhythm is a sign that your SA node is the main stimulator. It should be. Now, what we're gonna see is the P wave right here, right? The start of the P wave is not the start of when the atria actually contract, right? This is just telling us when they electrically activate. Halfway through this electrical activation, from this point on, that's when the atria start to contract. So you have all the calcium that needs to be released and be brought in even, right? You need that calcium to bind to troponin. You need troponin to move tropomyosin. All of that's happening, and it takes a little bit of time. So halfway through our P wave, that's when the muscle actually starts to contract, the atrias. Then there's a little bit of a, and space where it kind of moves back down. That's when you're contracting the muscle and then ejecting the blood into the ventricles, right? Then what happens? Well, at that point, nothing happens because we're ejecting into the ventricles. And remember, there's a delay at the AV node. So then you can contract the atrias, move blood to the ventricles, and then relax the atrias. Then we stimulate the ventricles. Once all of that is done with the atrias, now we stimulate the ventricles. And take a look at the ventricular stimulation. It is big, all right? And it's called the Qrs Complex. It's big because the ventricular muscles are much larger than the atrial cardiac muscles. It has to be, right? The atria just have to contract and bring blood a few millimeters to the ventricles. The ventricles have to eject blood and bring it throughout your systemic circulation, to your brain, to your arm, to your abdomen, right? All the area of your body. And it has to eject it on the right side to the lung. So it has to be a stronger contraction and a more powerful contraction. What we want to see in a QRS complex is a very narrow, very kind of peaked QRS, right? Peaked meaning that it goes up high. We know that when we stimulate it, you're able to contract almost immediately, which is good. If there is a lengthening, then we know there might be an issue, all right? Which can be, something is a pathology. So we want to be nice, large, and thin. That's what we want to see in a normal, healthy QRS complex. Now, what does a QRS complex kind of indicate? A functional AV node. When we see the P and the QRS together, we know that our cardiac conduction system is good. The last thing we see is a T wave. The T wave, and what happens at QRS, right? Once we're done with it, you go back to the baseline, and then a little millisecond later, we see a T wave. The T wave means ventricular repolarization. That's when the ventricles, halfway through, start to relax, right? QRS, right? At the R complex right here, when it goes up, that's when the muscle of the ventricles will contract, right? And that's when you kind of sustain that pressure develop the pressure enough to eject blood out. Halfway through the T wave, that's when the ventricular muscles start to relax, and at that point you can't eject as much blood out because now some of the muscles are going to start relaxing in the ventricles. So you can only sustain that contraction for so long before the actual ventricular muscles need to relax. Eventually, once we're halfway done with it, right, more and more muscles start to relax. By the time we're fully done with the T wave, right, a lot of the muscles in the ventricles have relaxed to the point where you're no longer ejecting blood and you're no longer sustaining blood pressure, which is what we want at that point. We want to be able to contract and then relax. Now, we don't see atrial repolarization because when the atria is repolarized, well, that happens about the same time as a QRS. And the QRS complex is so big that it masks any atrial repolarization. Keep in mind, right, repolarization, depolarization is not when the muscles actually start to contract, right? It's halfway through the depolarization when the muscles actually contract. Halfway through the repolarization is when the muscles start to fully relax. So right here, well, I'll show you some examples of a healthy EKG before I show you some abnormal one. So when you take a look at this normal kind of readout right here, notice that you have some of these that kind of faces down, some of these that faces upwards. When we do the ECG today, we will have, right, some leads, some electrodes on your legs, right, and arms. We only have a 3-lead electrode system. When you go into the heart, or when you go in to get your physical, right, you guys are young, so you might not have this yet, but you're like me, and every year they do, like, you know, they want to see if your heart is fine. So 3 leads, 3 electrodes is not good enough. What they'll do is put more electrodes on. We want complete 360 coverage of the heart. So then if there's any issues at all, we can see, right? If you have an issue in the posterior wall, we can tell. Anterior wall, we can tell, right? Now, what happens? Why am I mentioning this? Right? We can have a 12 electrode or 12 lead system. And remember, right, the first 2, usually the waveforms deflect upwards because it goes from here, here, and down, right? Remember, as we stimulate the SA node and the AV node, that wave of stimulation happens from top right downwards. So if the electrode is like further down on that side and it's following the pathway of the electrical impulse, what happens is that, like the first 3 right here, right? When it follows a pathway as an electrical impulse, when we measure it, the deflection moves upwards. When we have waveforms that are downwards like this, that's the way we are going to measure it because it's on the back, right, of our heart. So it's moving away from the electrode. As it moves away from the electrode and not towards it, then it deflects downwards. And that's, depending on the lead, can be a sign that it's actually healthy. That's why I want you to see that some of these are deflecting down. And you're probably wondering, why is that normal? Well, it is normal because of the way the electrodes are placed in your body. It should be deflecting downwards. So here, when you look at these, right, you see a P wave, a QRS, and a T. P, QRS, T. Normal sinus rhythm. P, QRS, T. Now, in these, we can also tell generally what the heart rate is at. So when I look at the start of the P wave, right, the QRS right here, if I was, and you see one small box right here, and another small box here, right? For each small box, if we have another QRS, if we start right here, and if we have another QRS right here, your heart rate is at 300. Not good, right? Obviously, nobody's going to survive that. Now, if we have another box right here, and we have a QRS at that box, I can measure your heart rate as 150. Then the next box, if I have it right here, right, and I see a QRS, we'll say your heart rate's at 100. And then next one over here, where this one is, right? The next one, heart rate's at 80. So we can measure the heart rate just by looking at these tiny boxes. And that's why you always watch those videos or old movies or Grey's Anatomy and you see doctors with their compass out measuring things, right? Is because with these boxes, you can measure things. You can measure the heart rate just by looking and by measuring, right? Now what else? We can also measure how high these QRS waves, right, deflect up. We can measure it, and we have a chart that tells us, all right, this is a high healthy, this is really bad as well, if it's a really low or really, really high. Or we can measure it when the ST segments are very prolonged. What do I mean by this? All right, notice you have a QRS, and then it comes back down, and then you have a T wave. QRS comes back down to baseline, and then a T wave. That's what we want to see. A QRS that goes up and down, goes back to baseline, and then a T wave. All right? In a second, I'm going to show you what's called an ST elevation, which is a sign of a previous myocardial infarct. Right? Here, QRS, down, and then T wave. All right? So this is all pretty normal right here. Next, I want to show you what happens when you have ST elevation. And this is a sign that you have an issue, either have had, right, or in the middle of having an issue. Now in an ST elevation, they don't, all right. I want to see like a huge lead right here. Right, so right here, you have a QRS, and then it stays up. See that? It doesn't go all the way to the baseline, and then a T wave. Normally, remember I mentioned, you have a QRS, then it goes to baseline, and then you have a T wave. Here, in every single lead, every single one, it never goes to the baseline. See that? And now here, you can actually see it on these leads, and it's very drastic on these leads. Even here, QRS stays elevated, then T wave. When we see this, and then we see somebody also complaining of chest pain, and then we see somebody also having a rise in the troponin levels when we do a CBC, immediately, that's a gold standard of having a diagnosis of an active myocardial infarct. The problem is this: once you have this, your cardiac muscles don't heal. They don't repair itself. They don't regenerate. So once you've had this situation, you will, from that day on, your ECG will be very different than what it was a day before even, right? Before you've had an MI. So why am I mentioning it? So what happens is, if you survive this MI, you will have changes in the EKG permanently. So let's say 10 years later, you have another MI. Well, you know, obviously, if we just look at your EKG, it'll be forever changed from the previous one. So what we need to do is compare the new EKG to the one after your MI to see if there are any further changes in an EKG. Your cardiac muscles never repair itself. So the most common cause of death in an MI, the first 24 hours, is shock, right? Shock is low blood pressure. And what happens is, so much of your heart muscles has died off. You can't create blood pressure, right? And then you die because of that lack of blood pressure and lack of blood flow as a result. After 24 hours, the most common cause of death is an arrhythmia. Now you have a sizable portion of the ventricles that now are dead. Now they don't receive the cardiac signals because they're dead, but there are some that might survive, right? And now they don't receive the message because they're further downstream. And now you have this miscommunication that develops and causing an arrhythmia. So just because somebody has survived that initial MI does not mean that they're stable, that they're able to be released. Whoops. Oh, all right, so all of these as well. Here we see a heart block. With a heart block, you have a P wave. You should have a QRS, but you don't. All right, so we're blocking the activity of the AV nodes here. All right, that's where we call it a complete heart block, right? What happens? Well, every now and then you'll have a QRS. Right here, you have a QRS but no P wave. So what happens with a heart block is there's no more communication. The SA node should be driving everything, right? It should be causing a P wave. Then it should be stimulating the AV node. But what happens is there's a miscommunication. The SA node fires correctly, but the AV node can't direct this communication to the ventricles. So the ventricles are not able to contract when it should. So for here, we should see a P wave, and then we should see a QRS right away. But we don't, because the AV node can't send that message to the ventricular muscles because the bundle branches have been kind of, cut off or blocked, right? And you can see it here. And because the ventricular muscles don't know and is not receiving the message about when to contract, it contracts whenever. That's why you see it contract by itself. No P wave. But you see a contraction here, right? No P wave around this one, right? It contracts by itself. There's no order to these anymore. Now, some of you guys might have had this before, a PVC, right? Premature ventricular contraction. With a premature ventricular contraction, and it happens every so often, and is more common in women. It can also cause panic attacks and anxiety attacks because of it. You can imagine, you're just sitting there relaxing, all of a sudden your heart contracts when it shouldn't, and as it contracts, it doesn't really move any blood out, right? And it feels like your chest just heaved for no reason. And you can see it right here, right? This person, if you're having this many PVCs, she probably needs to get some ablation done right here. Here, I'm saying she because it's more common in women.
You say a panic attack or what else?
It can, right, cause panic attacks, right? Usually it causes a prelude to it because you're having all these, premature ventricular contractions, and now your heart skips. That's what it feels like. Now, prolonged QRS right here can also be caused by, right, kind of a delay in the messaging of the ventricular muscles. Out of all of these, the worst one is this one, right? AFib, you can survive, right? What happens? In atrial fibrillation, the atria should contract and eject blood to the ventricles. Fibrillation means that it just shakes, right? And what we're gonna see is atrial contraction is really important when your heart rate is over 120. Before 120, even if it's like 190, right, we have enough time for ventricular filling from the atria, just to go by passive means, right? But when your heart rate is at 150, there's no time to passively fill blood from the atria to the ventricles. You're contracting 2.5 times a second. And we'll talk about that in just a second, a little bit more detail. Yes?
So what is a heart murmur?
I'm sorry?
What's a heart murmur?
Oh, heart murmur can be something different. Heart murmurs we do not see on EKG. EKG only diagnoses heart arrhythmias. So there's that difference. We'll talk about heart murmurs in a second, right? Heart murmurs are heard, right, when you're doing an auscultation. You don't see it on an EKG. EKG shows you when there's an electrical conduction problem. Now the hard thing about heart murmurs is you need somebody really well trained to hear it, right? And you need to find somebody that can actually diagnose it and then kind of understand when it's happening and what is happening, right? We'll talk about how in just a second that we can hear it, and then we can figure out, all right, is it your, right, atrioventricular valves, or is it your aortic or pulmonic valves? There are ways that we can have of deciphering it just by listening, which is crazy, right? So AFib is this, right? The atria just kind of shake instead of bringing blood in. Now you guys have seen those commercials for Plavix, right? Or blood thinners. When the guy's like, oh yeah, I have AFib, and then he's just driving around like, and nothing's wrong with them in their truck, right? Well, AFib you can live with, right? Now, the weird thing is this, even if you go to the emergency room and you're in AFib, you would think I want to shock you back into normal rhythm right away. No. Usually what happens when you're AFib, because the atrias are just shaking and not ejecting and contracting, right? There's no strong contraction of the atrial muscles. What happens is blood has a tendency to pool there. And what happens when blood pools? It clots. So if I would shock you back to normal sinus rhythm, there'll be a lot of blood clots that I'm going to eject. So what normally happens is when somebody's in AFib, we wait. We give you blood thinners so then we can get rid of as many clots as possible, right? Once I measured your INR, right, and that tells you if you're, what your blood clotting rate is, all right? Once your INR levels are sufficient, then I start to shock you back to normal cardiac rhythm. That's why you'll see videos on YouTube, I know, right? They'll see people like, oh, you have AFib, and then, they have enough time for them to have a friend take a video of them as the doctor shocks them back to normal rhythm. And it's always pretty violent when they do that. But there's enough time for them to actually get a friend to videotape it. And it's real, right? They actually do wait. They wait, they give you blood thinners, and then they will shock you back to some normal rhythm. The reason why they wait is because if I would shock you back to normal rhythm, there'd be so many clots that I'd just be ejecting everywhere. I'd have numerous pulmonary emboli, and God forbid, strokes that can develop as a result. That's why we want to dissolve the clots first, right? By giving you heparin and warfarin. Now, with ventricular fibrillation, there's no waiting, right? Ventricular fibrillation, the ventricles shake instead of contract. And I'm going to show you a video later on of a cow or pig heart where they stimulate it like this. And you can see how much it shakes and how little it actually contracts, right? So with ventricular fibrillation, because the ventricles are fibrillating and not contracting, you're not ejecting blood out of the ventricles. So you're not having blood going into your brain or anywhere in your body. Obviously that's bad. At that point, that's when you need immediate cardiac shock, right? You need that AED machine that we have that's floating around here. If you don't, you're not going to survive, right? Because you're not injecting blood at that point when you're in VFib. And if you don't get that blood circulating again, right, you're not going to survive. So this is an emergency. This is acute. You need to be shocked back to normal cardiac rhythm. This can be emergency. Usually, though, we have time to wait, right? So then we can give you blood thinners, and then we shock you back to normal cardiac rhythm. And kind of this, this kind of explains everything here. Again, with tachycardia, right? The big thing is this one. If there's a heart rate in excess of 100 beats per minute, at rest, right? At rest. That's what they should put, at rest. Because if you're exercising and your heart rate isn't at 100, yeah, you're not really doing much. So at rest, that's tachycardia, greater than 100. Now again, a lot of this, like AB block, SANO block, I'm not going to ask you that on the test, all right? That's a little bit too much pathology, and Dr. Khan would be mad if I steal some of her, material for next semester. Right. Let's talk about a cardiac cycle. What's a normal cardiac cycle? How does it work? Now, this cardiac cycle, let me see if I have that. Okay. Really discusses the material here. This slide, and I do have videos up on the slide already,